Hi, I'm Kim Adams, and our web chat today is going to focus on neck and back pain, something probably most of us suffer from at some point in our lives, from the most conservative non-surgical options to surgical options. And joining me is neurosurgeon Dr. Richard Vena and Dr. Ann Monroe, who is something I must admit I just heard of today, a physiatrist.
Yeah.
Tell me what it is. What do you do?
A physiatrist is a doctor that has training in a specialty called physical medicine and rehabilitation.
Okay.
And the whole focus of that specialty is in restoring function and independence, as well as improving quality of life to people who have lost it, whether it be from a disabling disease, from a stroke, or from pain, such as joint pain, neck pain, back pain, etc.
Okay, and you are both from the Michigan Head and Spine Institute.
Correct.
And I was surprised to find when I went on the website, there are lots of doctors with the Michigan Head and Spine Institute and also lots of locations, which for me is wonderful because to find a good doctor, sometimes you have to travel, you know, up to an hour to get to a good doctor, and there's so many locations across Metro Detroit.
Yes, they've how many? 13 neurosurgeons and counting, I think, last time I checked, and 5 physiatrists, with 4 of them having specialty training in pain management. And not only those specialties, but as well as physical therapists, occupational therapists, chiropractors. So a wide range of specialists, specialists that are employed by the company.
Well, good. Well, we're going to have a really informal chat today, and if you just type your question below, or you can call and you can get great advice from the doctors. You just type in your question for us, or you can call. The number is 248-356-0077. If you're not sitting next to a pen, it's 248-356-0077. And let's start by just kind of talking about, you know, what types of back pain people have, and when you think it really should, and this is probably for you, when people have to make that next step to surgery.
Yeah, well, you know, back pain is very common. We see a lot of people suffering from back pain. So, you know, even though I'm a brain surgeon, probably 80% of what I do is actually spine-related, whether it be neck pain or back pain.
Really, 80%?
It's very common. You know, all day, every day, seeing people suffering from sometimes very severe neck or back pain. It can be very, very problematic. You know, surgery obviously is on the list of things to do for pain, but there's a whole host of other things that you try that are non-surgical first, with people with, like Dr. Monroe, to try and run the whole process, trying to find something that'll work to reduce pain and, like she says, improve quality of life without taking that ultimate step to surgery. Unfortunately, sometimes all those things don't work, and sometimes people are looking at having a surgery to try and address the problem and make it go away or improve it.
So you do find that not everyone does in the end require surgery. They can really have success with these non-surgical treatments?
Oh, certainly. In fact, it's the minority of patients that end up requiring surgery. And one of physiatry's goals is to maximize conservative or non-surgical pain management to help people try to avoid having to take that final and ultimate step, surgery.
That's exactly right. About 10% of people that come to my office doors actually get surgery. The other 90% we're able to manage, again, with the non-surgical interventions so that people can get on with their daily life and not need surgery. So
let's talk about some specific therapies that are non-surgical treatments to help people with their back pain.
There's many, and of course each patient and each case is different, so the treatment plan is always tailored to that specific case. But in general, it can include medications. There are injections for pain that can be done. There's the prescription and management of physical therapy, occupational therapy, and even referral to chiropractic manipulation, just to name a few of some of the modalities that we will use to try to help treat and manage pain.
Well, that was something you brought up, the chiropractic part of the Michigan Head and Spine Institute. I think that's something that a lot of people don't associate with, you know, traditional medicine, and then the chiropractic element all housed in one facility. I think that's pretty amazing.
Yeah, there are a lot of different, as I said before, modalities for pain treatment, and chiropractic medicine is certainly one of those. There are some people who get fantastic relief with one specific modality, but in general, it takes a group or a team of specialists, the physical therapist, the occupational therapist, the chiropractor, including the physician, to really bring together a team effort, a collaborative effort to treat pain and maximally so.
Yeah, and Michigan Head and Spine has done a great job over the last 15 years and really collecting all the specialists under one roof so that it's not just the surgical piece anymore. Patients that are having pain in the back or neck, like she says, can kind of show up and knowing that they're going to have all the options ready for them. Like one-stop shopping, like you said.
Well, exactly, and for someone, like myself, I'm a busy mother of 3. All of us have children. I don't have time to go to 5 different doctors all over Metro Detroit. I just need to go somewhere and get it fixed quickly, which is why I was just so impressed that you really do have everything in so many locations to serve Metro Detroit.
It makes it so easy and efficient as a physician like myself or managing pain management to be able to have all those specialists within that group. It makes it not only easy for me but also for the patient, which is one of the wonderful things about MHSI.
Absolutely. Well, we do have a question, and it is, what are some pain management options, and should I worry about, and this is a good one, should I worry about an addiction to medication?
The pain management options are what I talked about before. Not only oral medications, injections, physical therapy, etc. Addiction is something that gets a lot of press, so I think the public's view of it is something that's much more prevalent than it actually is. True addiction, and even a lot of untrained physicians have some misconceptions about what addiction truly is, but it's actually a very rare occurrence. And if you have a doctor who's trained appropriately in the prescription of those types of medicines, and so when you're talking about addiction, usually you're talking about the opiate class of medicines.
Right.
They should know all of the things to ask each and every time you come in. They should be able to go over with you the signs to look for if that were something that were going to happen. And then there are things that can predict whether or not somebody is going to have maybe a predilection to developing an addiction to those kinds of medications that you can look for and screen with questions before prescribing it. But in general, it's a very rare thing that happens. And when you're with somebody who's appropriately trained in that, though, it can be monitored for and then treated if it's something that ends up becoming an issue. Yeah. But for most people, it's not.
I would agree with that. I mean, around the time of surgery, obviously patients have postoperative pain that we have to deal with.
Right.
And as long as you have an established relationship and it's an ongoing relationship that you're monitoring and watching closely the medication usages, again, true addiction through trained specialists is pretty rare. We don't encounter a lot of that. We're able to monitor them and get people off those medications as quick as we can, before or after surgery as their treatment progresses. So it's not as much as an issue as people think.
Right. And you also have other options, I would imagine, because you have more natural treatments available to them, so that probably makes that transition from the pain medication to more natural treatments. I would imagine there's a physical therapy element.
Whenever possible, we try to avoid having to use those types of medications. And obviously, they have their place where they're appropriate to use, and we always hope that it will be, if we have to use them, it will be in the short term. And it is the rare few that end up requiring them in the long term. But again, you do that with trained professional, and you do it carefully and slowly, and you do it in an educated way.
Okay. Once again, we are talking to doctors from the Michigan Head and Spine Institute. We have Dr. Ann Monroe and Dr. Richard Vena, and we have actually a phone question. And again, if you have a question you'd like to call us rather than type it in, it's 248-356-0077. And on line one, we have Raymond from New Boston. And let's see. Let's talk to Raymond. Raymond?
Hi there.
Hi. What is your question for us?
Okay, I just had a CAT scan done, and they're saying that on the C3, 4, 5, and 6 that I have arthritis, and that they want to give me an injection in my neck area. And why they do it, they're doing it like with X-rays to make sure that they hit the right area. I don't know much about it, but it sounds a little bit, sort of scary. I was like, what exactly is that?
What they're talking about is doing something called a cervical epidural steroid injection. And that injection involves placing a needle right outside of a special sac that holds the spinal cord, and placing steroids within that area and letting them bathe the neck in steroid. Steroid offers pain relief as well as decreases inflammation. And for some people suffering from a great deal of pain because of those, and I'm going to assume by arthritis you mean some disc herniations and some changes that go along with degenerative disc disease. Yeah, those injections can offer a lot of relief. The educated patient or the doctor should tell you, though, that it is possible that that those injections will help only minimally, but though some people do get a great deal of relief from them. And it's just one of those modalities or treatments that you try and you see, and if done in trained hands, is a very safe procedure.
And it could help a lot, or it might not help.
Correct. Yeah. And so you, like I tell all my patients, you weigh the risks of the procedure with the benefit of the procedure, and your physician should be able to go over all of that with you, and then you decide for yourself if it's something you feel is worth trying.
Well, is there like anything that I could just take orally, that some type of pill that I could take that way that might help out better, or the same?
No, not better. If you're talking about pain, especially when it's chronic pain, for my patients, when they ask that same question, because a lot of people do have fear of these procedures, and in truth, they all are relatively safe, especially when done in trained hands. But medications, for me personally, I would choose to try an injection before I would consider oral medications, because oral medications, they're not going to change what's there. They don't take the arthritis away, and so they really are just masking the pain, which in truth is what the injections are doing as well, but there's much less of a side effect of the injection as opposed to going to taking, let's say, chronic opiates, where you need to take them every day, multiple times a day, to keep the pain under control. Where an injection, you get a series of 3, and in the best case scenarios can sometimes have up to a year's worth of significant pain relief, which I find to be a much better option than having to take medications on a daily basis.
All right. Well, thank you very much.
Thanks so much for calling, Raymond. We appreciate it.
All right, thank you.
Well, remember, if you're suffering from head and neck pain, you really do need to take the professional's advice. You can call the experts at the Michigan Head and Spine Institute at 1-877-784-3667 to schedule an appointment today, or you can visit www.mhsi.us for more information. Dr. Vania, you see patients in Mount Clemens, is that correct?
Mount Clemens, and also in Detroit at St. John's.
Okay, and Dr. Monroe, where do you see patients?
I see patients in New Baltimore, Novi, and Southfield.
So that pretty much covers the area just with the 2 doctors, and you have many more doctors as well. Well, we have lots of emails now. Kathy from Trenton. I have some degeneration around my C5 to C7 and often have pain in my neck and upper back, as well as tingling in my arms and fingers. What is your suggestion for managing the pain? And I think a lot of people want to know this, is chiropractic care safe?
Well, it sounds like she knows that she has some degeneration at that level in her neck. I'm assuming an MRI was done. Obviously, like the last caller, Raymond had said, I mean, arthritis is kind of a universal condition. No one gets through life with normal discs and a normal spine. There's some natural wear and tear that goes on, and at times enough to cause pain or significant pain. But I think sometimes there's you got to draw that line where if people start getting neurologic symptoms in their arms, like numbness in the hands or tingling or frank weakness in the arms or legs, that's more concerning for a significant nerve pinch, which sometimes is best addressed with a surgery to unpinch nerves to make sure that there's not a permanent damage that goes on. So sometimes it is nice to see those images and see to make sure that there's not compression of the spinal cord or nerves in the neck that might lead to long-term damage. So when Kathy from Trenton says that she's having some tingling in the arms and fingers, again, that'd be one thing you'd want to make sure that there wasn't significant nerve pinch, and look into other causes of numbness. Frequently we run into people that have arthritis or nerve pinches in the neck, but they also have a carpal tunnel syndrome that also causes numbness in the hands and fingers.
Oh, okay.
So again, just a good, thorough evaluation by a doctor will help tease that out. to see what might be necessary. And depending on the severity of the changes, again, running through the whole gamut of care for the pain, whether it be medications orally, by injections, physical therapy, conventional physical therapy, chiropractic manipulation. Some of the things we keep hitting on over and over, these really are kind of the list of the kind of the laundry list of treatments that we use to manage pain.
Yeah, and discussing the last part of that question as far as whether or not chiropractic care is safe, I guess it's kind of common sense, but it is if you're in very well-trained hands.
Right.
And my recommendation would be to find somebody, if you're considering chiropractic care, who is very well trained, who comes very well recommended. It's generally not something that I will recommend unless I know the person that I'm referring to. And thankfully, the chiropractor that we have at MHSI I know very well. I see a lot of his patients, and so I know firsthand the kind of positive responses that they have, even for the problem that she's talking about. So a good chiropractor who's been doing this for a long time and is very well educated will know the kinds of things he can and cannot do based on the pathology or the problems within the neck or even in the low back. And in those cases, you are in safe hands. They can be safe.
Okay, great. Well, we're getting calls and lots of questions for the doctors today. We have, let's see, Denise from Dearborn. Hi, Denise. How are you?
I'm fine, thank you.
You have a question? I'm good, thanks. You have a question for our doctors today?
I do. I had a lumbar fusion in July. It started out with 3 discs, one on my right side that was resting on a nerve that was causing my left leg to be totally, I couldn't walk for more than 5 minutes, and the pain was excruciating. And the fusion worked well. I stayed in the hospital for 1.5 days. I came home. 9 days later, I was in the hospital with a horrible infection. And I was there 5 days for that, and then they sent me home with the home care, who I was doing an IV 3 times a day myself, which all the medication I was under, I wasn't quite sure that I should have been doing that myself. And then the cheat sheet that they gave me for 1 through 30, instructions, never said ever. And they also noticed this when they would come, because I would call their 800 number a lot. Never said to close the clamp on my PICC line. And so I ended up with blood clots. I ended up back in the hospital with that.
Oh, no.
And what I've noticed, the main thing is, I take a little walk, go for walks, and I've been doing that. But then the next day and the day after, I have the worst, hip and pelvic pain, and I have, nerve damage in my both sides. That is very painful. I'm taking Lyrica, I've got Darvocet, and it keeps delaying my therapy and delaying me going back to work. And this has been since June since this happened, but all the appointments were so hard to get with everybody. Everything was 2 weeks. 2 weeks to get the MRI, then it was 2 weeks to see the neurosurgeon. And it was just, I don't know what to do. Last night I had a fever that I almost called 911 for, because I didn't want to wake up any of my nearby, sisters and brothers at midnight. But I was just shivering and shaking. Tylenol, it did go away about 1 in the morning. But is there anything else that I can be doing here at home? I go for another MRI tomorrow on my thighs. It's like, how when you have a fever and your skin's real tender, and it hurts, feels like it's burning from the inside out, my skin.
Yeah, well,
just on my thighs.
Yeah, Denise, I think you have a great question. I think that highlights a lot of things that are probably worth talking about. The lumbar fusions are big surgeries. Again, those are one of those things that you put down toward the bottom of the list for options for patients. And that's one of the reasons why we always make sure that surgical intervention is, again, more toward the bottom of the list, because it does come with some potential risks and complications. Your story kind of highlights some of those that, as a surgeon, that we worry about. The risk of infection, thankfully, is pretty darn low. It's on the order of about 1% or less in most surgeons' hands. You just happen to be that lucky 1%. that ended up with an infection, and they can be pretty debilitating, and there's a lot of extra care that's involved with that. You know, but the infection will eventually clear with the antibiotics and the appropriate care that you're getting. You know, but the bigger issue I think for you is you know, lumbar fusions. Again, they're big surgeries and they take a long time to recover from. I mean, you generally.
I know. I feel like a prisoner in the tower.
Yeah, I mean, generally.
Drive because of my legs and.
Yeah, I mean, generally we tell patients it's good 3 to 6 months recovery time on the short end if you're a fast healer. You know, some people that have other medical problems, you know, they're diabetic or, you know, for whatever reason they're just slow healers, it can be up to a year before they really feel like the surgery is done and they can put it behind them and move on. So it's a long process. It's not an overnight success.
Yeah, and my surgeon has been fantastic. I mean, you can't even, I can't feel, because I've never seen, I had my sister take a picture with my camera phone because we're going back in for exams and like, well, you know, I don't know why it's leaking here, I think it's leaking here. And
Yeah.
infection coming out, you know, and I stayed bandaged up for quite some time. And I could never see what they were talking about. And so I had my sister take a picture of my back on my phone so I could see. But, I mean, I can't even feel.
Yeah.
I still get, I notice when I take my walk, and then I live upstairs on the second floor, so coming up the stairs, by the time I get upstairs and after the walk, I'm dripping in sweat, and I mean, how chilly it is out. I try to take it in the evening, you know.
Yeah, and these are the things, again, that I think with time, you know, once you get through further through the healing process, and at some point in your future is physical therapy to deal with all these issues that people get, because it's almost like a domino effect. I mean, you start with the back surgery because of the pain and debility from the surgery. Again, your legs are weak, your knees are weak. You know, you're hobbling around for weeks or sometimes months after these kind of surgeries. So it's something that again, you need a fair amount of time to recuperate from.
Thanks.
So good luck.
Thanks, Denise. Thank you for calling.
All right,
Hope you do
now.
better soon. Okay, we have lots of calls, so if you're on hold, I apologize. We're going to get to try to get to all of them in this next, what do we have left? About 40 minutes. We have line 3, which is Lisa from Detroit. Lisa, I'm totally with you on this one. Back pain after an epidural. I'm sure you deal with this quite often. Hi, Lisa. How are you?
Hello?
Hi, Lisa. Can you hear us?
Lisa?
Yes, Lisa.
Yes, I'm fine. How are you?
I'm good. So you have suffered back pain after an epidural, which is, I think, what a lot of women have suffered through.
Yeah, that's happened to me, and I've been suffering with this lower back pain ever since I had my child at 21, and I'm 53 now.
Oh, wow. Is that common?
I mean, it's like I can't stand and wash my dishes. I can't even put clothes in my washer and dryer without my back hurting so bad.
So I want to be clear that I heard it right. You're talking about pain after an epidural done about 30 years ago?
Yeah.
Yeah.
And when it happened to me, that when I got home, I couldn't sit up, and I went back and forth to the doctor, and they would just give me muscle relaxers. Some of the things they were doing wasn't helping. I wasn't able to hold my baby for 3 months.
That's it's gonna be a hard question for me to answer. This is something that I hear. I don't see a lot of patients with this history, but this is something that I hear a lot about as especially older women come in to talk about new epidurals for back pain. And the epidural that's done for back pain is slightly different than the one that's done when you're having a child. And how they changed the way that they perform those from 30 years ago to now is not something that I'm familiar with. So it's going to be difficult for me to really try to figure out why that would have left you with this pain 30 years later. But it's something that I hear a lot of people talk about, reasons why they're afraid to undergo an epidural for pain, or why they don't want, their younger child or sister or friend to have it done. Because
is it normally just a short-term pain
in general,
for most women? Like
in general, the
very short-term.
Well, currently,
right?
Whether you're having the epidural for back pain or whether you're having it because you're going through childbirth, it's usually just a muscular pain, needle trauma through the muscle, which is unavoidable, and then it self-resolves after a few days.
Right.
So it's extremely unusual for it to last that long, but like I said, that's been something that's more common.
I'm having trouble hearing you. It's kind of fading out.
Okay, Lisa, well, we appreciate your call, and we hope we've answered your question today. We have lots more questions to get to. We have Faye, let's see. Faye from Rochester Hills, are you there?
No, this is Angela from Rochester.
All right, well, we'll take Angela from Romulus. Hi, Angela, how are you? Oh.
Oh, that's a great question. You know, there are again other options. You know, other than things that you've listed. And I think sometimes too depends on the length of time someone's suffering from those symptoms as to how much more aggressive you start to get. And depending on the degree of the bulge, the degree of the compression on the nerves. Again, when someone's been suffering for 4 years, sounds like for you. Again. I think somewhere along that continuum of care is actually seeing a surgeon at some point to see if there's anything that might be done from a surgical standpoint that might help you. There was a question about a laser spine procedure that you had. Yeah, laser surgery has been used in spine surgery, but it's been quite a while back that you have to go, like maybe back in the 1980s when the lasers first came into spine surgery. It was going to be the hottest, greatest new thing, and then after a while they realized that there was actually a lot of nerve damage, a lot of complications from using lasers in spine surgery. So it quickly fell off the map about as quickly as it came on the map. So we don't really use lasers much anymore. There are a couple of places in the country that advertise for laser spine surgery, but as of 2010, it's definitely not the standard of care and not something that I would really put much credibility in as of yet. You're welcome.
Thank you for calling, Angela. I just want to, for those of you who are just joining us, Michigan Head and Spine Institute, we're talking to two doctors from there today, Dr. Ann Monroe, who is a physiatrist, which I keep saying slowly because it's, again, a term that I think a lot of people still aren't quite familiar with, and Dr. Richard Vena, who is a neurosurgeon. And again, both of them are from the Michigan Head and Spine Institute. And if you are suffering from neck and back pain, which I'm sure many of you are, you really should take the professional's advice. And you can call the expert physicians at the Michigan Head and Spine Institute at 1-877-784-3667 to schedule an appointment today, or you can also visit, while you're online now, www.mhsi.us for more information. We have lots of calls here. Again, this is Faye now from Rochester Hills, and let's see. Hi, Faye, are you there?
Yes, hello.
Hi, do you have a question for our doctors today?
Well, I've been listening to the other questions, and some of them sound like, one of them particularly sounds like a problem I've been having regarding it was an epidural. The lady said she had about 30 years ago, and that was when her problem started. But I had it wasn't called epidural in those days. It was called a spinal block. Mm-hmm. And I've had problems with my lumbar spine ever since. And now I guess it's just turned into arthritis because I think it's when they insert the needle, it hits a disc. And that disc has turned into a herniated disc. And now it's turned into arthritis of the lower back. And I'm thinking that it's gotten very bad. Instead of taking a lot of pain pills for it, is there some other treatment, perhaps?
Well, it's a lot of the treatments that we've been talking about. It's trialing physical therapy, which you may have already done since you've had the pain for so long. The oral medications, trying to get the pain under better control. At your point with this history, I'm sure injections aren't something you're willing to consider, which is completely understandable. Though every once in a while I do get somebody who I can convince to try it again, because, like I said, it is done in a different way now. And chronic pain after an epidural is not something that I see often at all in recent years in medicine. But after you've maximized those treatments...
Did you say injection?
Yes.
I haven't had that yet.
You haven't tried that, yeah. Usually for people who are very gun-shy about having an epidural done because of a problem that they perceive as having started with or coming from a previous epidural, there are other ways to get the steroid into the spine to see if that might not calm down some of that pain and inflammation coming from the disc herniation or disc degeneration, whatever the case may be, that don't involve repeating the same type of procedure that started the problem to begin with. So that is an option, and that procedure that I usually will recommend is a caudal epidural injection, where they can avoid that low back epidural space altogether, but still administer the steroid into the spine to see if that can help the pain.
How long does that last?
The pain relief, what I tell people is the pain relief is anywhere on a spectrum from it not helping you at all, so there is the possibility that you won't get relief from it, to almost complete resolution of pain for months and months and months. And of course, my goal is always 6 to 9 months with that. And then there's everything in between. And so, like everything else that I offer as a pain management physician, you take the risk with the potential benefit and you weigh that for yourself. And the nice thing about these, especially the lumbar, the low back procedures, is all of them are relatively safe. So there's very little risk with the potential for quite a bit of benefit. And so you take that and you make the decision with your physician about whether you think it's appropriate for you.
Okay, is that done on outpatient?
It is done outpatient, yes.
Okay. Thank you very much.
You're welcome.
Thanks, Faye. Thank you for calling. That brings up a question that I have. Could it be, we've heard now 2 women talk about the epidural, but could it be that they have other problems that develop, but that's what they trace it back to, so maybe that's not essentially the cause of it, it's just that's the only thing that might have been a coincidence when it started?
Yeah,
does that make sense?
Yeah, that's a great point. I mean, what Faye described is pretty typical. Again, as I mentioned earlier, everybody gets some age-related decline and degeneration of the spine. And it starts with an early drying up of the disc or a desiccation or degeneration of the disc. And as the months and years go by, there's, a gradual, progressive, further degeneration, further drying up, further collapse, further bulge. It's kind of a gradual decline of the disc. Typically, not always, but typically there's increased pain or disability that comes along with that. But what's really highly variable is the rate at which that disc declines. I mean, some people have minimal degeneration of their disc, which will be the same for 30 years, and other people might have a more rapid deterioration of the disc over 6 months or a year or 2 years.
And is that strictly genetic, or is it
genetics plays a big role in it, and I think a lot of it is the activity as to kind of what they're doing and how bad the initial injury was to the disc. If someone rips their disc in a car accident or something like that, obviously they're starting with a bad injury that sometimes the body just can't heal up, and they have a rather abrupt kind of further degradation or destruction of the disc from their initial injury.
Okay. We have another call. This is Mark from Berkeley. Hi, Mark.
Hi, how are you?
Good, how are you?
I'm having some pain in the left side of my neck. I hit my head on my car door roof a couple times, and I've been medicating myself with Aleve and Bengay. And it goes away for a while, but then it comes back, and even sometimes I have trouble a little bit swallowing sometimes. I got this new light release thing from the infomercial, but I haven't started using it yet. Is there anything you would suggest, or what? Oh, and I just got an MRI, or what's the other one? A CSI, MRI?
A CAT scan?
That's right. I just got a CAT scan yesterday at Botsford, and they're going to get it over. They had a free clinic for cancer of the neck people a couple of Saturdays ago.
With the problem swallowing, maybe that would be.
There's no swelling, but there's just a pain on the left side, not the right side, just the left side.
It's going to be a hard question to answer without being able to examine you. If you're having trouble swallowing as part of the pain coming from the left side of the neck, I mean, one of the answers to explain that may be some muscular injury. So swallowing can cause some of the muscles in the neck to contract, and that may be adding to your symptom if it was a muscular injury that you had with hitting of the head.
I don't have any swelling in the left side of the neck.
No swelling?
No swelling at all, no.
Yeah, you don't have to have swelling to have had a muscular injury. Outside of that, problem swallowing or something I usually will end up requesting, and tell me if you agree with that. That to me says something more about a cranial nerve more than it does about, or I guess an anterior disc herniation could also be playing a part in that. So you really would want to.
He took a picture of the C-rib, or what they call that, the C-rib up there, or something like that.
Probably the cervical spine is what he was looking at, I imagine.
Cervical spine, something like that, and it was a 20-minute scan, you know, and then they gave me the CD for it and everything. But is there anything you would suggest in terms of self-treating, you know, besides the Aleve and the Bengay?
Well, again, with the symptoms that you're having, it's hard to tell exactly where it's coming from. Is it muscular injury? Was it a disc injury? With the hit on the head, did you put some pressure through your disc, and now is the swallowing issue suggesting a disc herniation that's moving, that's kind of bulging forward, affecting the way you swallow? So it's hard to tell you or give you advice about what to do, because it's difficult at this point to clearly define what the problem is.
At this point, I would just
trouble swallowing when I have pain. When I don't have pain, I don't have trouble swallowing.
Yeah, well, you know, it's hard to find out the real cause of that. I mean, I think it's probably really important to follow up on those images that you had done with your doctor, whoever ordered them, to make sure that there's that everything's okay. And then
should I call you? Do you have that new machine that they advertise on TV? I don't know if you've seen it on TV.
Well, we do have the full imaging capabilities at MHSI, MRIs, CAT scans, X-rays. We do have that capability at our Southfield office. But I think more importantly is whatever.
What's the name of your institution?
It's Michigan Head and Spine Institute.
And the number, I think he asked for.
Oh, let me give you the number. It's, are you ready?
Wait, let me get a pen.
Sure.
Yeah, but I think whatever the doctor is that ordered those tests probably should be the one to follow up with you and make sure that you know, they have the first chance to look at those and see if there's anything else that needs to be done for you.
Okay.
Yeah.
So what's the number?
Okay, Mark. It's 1-877-784-3667. And again, we're...
1-877-784-3667.
That's correct. And again, it's
the name of the organization, Michigan what?
Michigan Head and Spine Institute.
Spine Institute, and they're in Southfield.
Well, they have locations all over Metro Detroit. I know you're in Berkeley, so I'm sure
I'm near
that...
Southfield.
Okay, then that would be perfect for you.
Okay, thank you so much.
All right, good luck,
Thanks
Mark.
so much for calling, Mark.
Take care.
You know, he brings up a good point. There seem to be so many different causes of back pain, and I would imagine everyone's just a little bit different, which must make your job a little difficult to pinpoint exactly what's causing the pain.
Not really. When you sometimes it can be difficult, but if you have a thorough history, if you do a thorough exam, usually the source of the problem becomes clear, and it's not difficult to determine when you're well educated in the anatomy.
And what are the most common? I mean, is there something that's the pretty common cause of it?
We see a lot of just overuse of muscles, muscle strains, weekend warrior type injuries. We see a lot of arthritis, just routine degeneration of the neck or back that causes pain. So the sprains, the strains, the routine arthritis, you know, we do see, as mentioned earlier, a lot of ruptured discs in the neck or back. So we see a lot of that. But the causes, there's lots and lots of causes of low back pain and neck pain, and sometimes what when patients are referred for quote-unquote back pain, it's actually hip pain or sacroiliac pain or other sources of pain that, again, like Dr. Monroe mentioned, a good physical examination, a good history will really help tease out the details of where the pain's coming from, and then using imaging studies, whether it be CAT scan, MRI, x-rays, to kind of help confirm that diagnosis. And then once you have a solid diagnosis, then you can kind of move forward with a good treatment plan.
And is it just inevitable that eventually we all get the back pain, or are there things that we can do to really improve our likelihood that we'll get a degenerative disease?
It's not inevitable that you get back pain. The degeneration of discs is something that begins from birth.
Right.
And there's some debate now, and he probably knows a lot more about that than me, about where that transition is from that normal aging process that happens within the discs, and then when it starts to become degenerative disc disease. But a lot of people have degenerative disc disease, so you can do an MRI on somebody who has absolutely no back pain, and they may show a lot of positive findings. And then you can get people who have a lot of pain and very minimal findings on an MRI. So there's not that great correlation, and I think there is a certain part of it that medicine just hasn't caught up with yet.
And that's an important point. I think sometimes you'll look at the MRIs, in the surgeon's office, we'll look at the MRIs before we go into the room to see the patient, and you'll see it's still a horrible looking MRI, like, oh my God, they're definitely going to need surgery. And you walk in the room, and they just came from the golf course playing, 18 rounds of golf, and they're taking one Motrin every few days, and I mean they're,
So it's just a different tolerance level.
Exactly. It's really individual as to how the body deals with those changes. Again, some people have very little, if any, pain, and other people might have just the slightest minimal degeneration of their disc, and they're in horrible, excruciating back pain.
Right.
So that's where the real
art. I have just a little bit of damage and just whining.
And this is where the real art of medicine comes into play, as to really trying to figure out the right path, the right treatment algorithm for that particular patient.
Okay, we have another email. This is Susan from Detroit, and she asks, how can I prevent recurrent sciatic nerve pain and treat it when it flares up? I stretch daily and take Motrin for pain.
I guess it would depend on the source of the problem. So you can have sciatic nerve pain because of one of the major nerve roots that's being pinched in the back that contributes to that nerve. You can also have pain in the sciatic nerve because it's being pinched as it comes through some of the muscles through the gluteal or buttock region. So there's different sources for it. So depending on what the actual source of the pain is, would determine what the appropriate treatment for it is. But certainly stretching, strengthening the core muscles that support the low back, as well as the gluteal muscles. And when you have a flare, finding a medication that works for you. If Motrin works well, that's a good medication to take as long as you're taking it appropriately. Sometimes one of the more common things that doctors like to give for flares and pain is something called a Medrol dose pack, where you're giving a strong steroid, which is a strong anti-inflammatory that can help subside that flare and pain. So it just depends on the patient. Some people respond to different things, but at home, stretching, doing some regular strengthening exercises.
I think people find their regimen that works well for them. After they've had a few flare-ups over the years, they find, if I stretch for a week and do a heating pad or sit in a hot bathtub, or they'll find their own little treatment plan that'll help bring them back down to their baseline.
I've seen recently that they're like pads almost that you put on that provides like a localized medication to your back. Have you heard anything about that?
There are a couple
Flomax or something like that?
There are a couple of topical patches. Lidoderm, which is like a patch that basically numbs the kind of superficial layers of the skin, and there's some more recent ones like a Flector patch. That's like a strong Motrin type drug that absorbs through the skin, so it gives you a very local anti-inflammatory action rather than taking pills for a long period of time, which can really burn your stomach. So the topical
That's what I was going to ask about the Motrin. Taking it for a long period of time, I would think that ibuprofen would be tough on your stomach.
It certainly can. They've actually done studies on people taking anti-inflammatories for weeks at a time, and there's a pretty high incidence of even just superficial ulcerations in the stomach. So you have to be real careful with long-term, high-dose anti-inflammatory use, and that's where, again, sometimes the patches will work well in that setting.
So definitely something you want to talk to your doctor if you're having a lot of pain and you just keep popping Motrin more and more to manage it.
Right.
Obviously, It's time to visit the Michigan Head and Spine Institute, I believe. We have another email. This is Larry from Waterford. My cousin was in a car accident and had a broken back. He had a compression fracture of the L3, but had a burst fracture of the L1. Can you explain the difference? And for those of us that aren't familiar, what does that mean, L3, L1?
Sounds like a question for me, probably. Well, you know, there's 5 bones in the lower back. You know, there's 5 lumbar bones, and we abbreviate it by lumbar 1 or L1.
Okay.
So obviously this person had a fracture of the top lumbar bone L1 as well as L3. And, you know, there's different nomenclature really based on the severity of the fracture. So if you have a compression fracture, that means the bones, which look kind of like these little, my little model.
So this is the lower back.
This is a model of the lower back, and this is kind of almost life size. So the big white blocks are obviously the bones, and these little squishy things in between are the discs, which are kind of like the cushions or the shock absorbers between the bones. And this little yellow thing that's in the middle here, that's the spinal sac that has all the nerves. Very important. And at each level, it gives off one of these little yellow things off the side, and that's a little nerve that goes down to a particular part of your leg. And so what happens with the compression fractures or burst fractures is that portions of this bone basically get scrunched. They kind of get crunched in on themselves. And if it's a compression fracture, you know, usually that just means that part of it's kind of wedged in. If it's a burst fracture, that usually means it's something more significant where there's multiple pieces, the thing is basically blown apart, so hence burst. So burst fractures tend to be more severe, and they can start to affect the stability of the spine, where they can't hold up the weight of the body anymore, and the bone fragments can shift around, and obviously that can be dangerous. So burst fractures, just by the name burst fracture, usually means a more severe injury, and quite often, not always, but quite often actually needs surgery to stabilize it.
Okay. You know, I have a question about, I have 3 kids, and 2 of them are school age, and their backpacks are getting heavier and heavier and heavier. I know I've seen some kids now with the rolling backpacks. Are you seeing more and more children in your office with back pain, younger people with back pain now?
You know, so far in my office, I haven't, but I don't see a lot of kids in my office. I'm mostly adults.
No,
neither do I.
Yeah.
So is it a risk? I mean, if my kid's bringing home these huge, I mean, I've looked at their backpacks and been like, oh my gosh.
The nice thing is about being young.
They're pretty resilient.
With that stuff.
Yeah, exactly, and without it causing any major damage. But of course,
So I'm
it's
okay to
always-
just say, look, just pick up the backpack and get to school. It's
Yeah,
not
and
being-
usually if it causes a problem, it's going to be more of like a muscular one.
Okay.
But
So
yes,
they're not going
you
to
are-
cause serious pain to their back.
No, they shouldn't. But it is better, of course, to carry the weight evenly, the weight at the back.
Well, they have the
was meant
rollers
to.
now, so
Yeah.
the kids, you know, roll all their books. You'd think with the computers they wouldn't have as many books. We have another email. This is Tom from Warren. I'm wondering what results, if any, have any of your patients had using, and you'll have to help me with this, X-spot interspinous spacers. Is that correct? Did I say that right?
That's correct.
I'm considering this option. I have a degenerating disc L4, L5.
Yeah, that's a great question. You know, what Tom is talking about is treatment of degenerative disc disease and spinal stenosis, which is spinal stenosis is a condition where because of a bulging disc or bone spurs or thickened ligaments in the back, that they start to kind of push in where the nerves are running in the spine. So stenosis in Latin just means narrowing. So if normally the space is this big, in the spinal stenosis patients, you know, the space is a lot smaller, so the nerves start to get impinged, and they don't like that. So the nerves, you know, will get pain in the back and down the legs, numbness down the legs, and people start having difficulty with walking or standing for long periods of time. So over the last few years, a company got smart and realized if we can just kind of prop that space open a little bit, that we can give more room for those nerves so that the symptoms will be less. So it's a great, much less invasive, almost a minimally invasive type surgery to kind of just wedge. It looks like a small little bullet that we kind of wedge in there between the bones to prop the space open. And it gives you just enough space extra to help improve the symptoms. Now that's in contrast to the usual treatment for spinal stenosis, which is what we call a laminectomy, which means going in there and actually drilling away some of the arthritis changes. Yeah, I'll pass on that one.
Yeah.
Drilling away some of the arthritis changes that are causing that compression. obviously more invasive. There's a hospital stay associated with the laminectomy. So the X-stop frequently is done as an outpatient,
Really?
and people, they're up walking around within a few hours after surgery. So it's a great minimally invasive way to treat spinal stenosis for the mild to medium stenosis. For the more severe compression of the nerves, it just doesn't give enough space. It doesn't work. But those are the advantages of it. Of course, the disadvantages, as there are with everything, is that about 10% of the time it doesn't work. Doesn't give you enough space, and you end up going back to have that second surgery, that definitive laminectomy, to go ahead and treat the spinal stenosis.
So you eventually do have to have the laminectomy.
Not always. Again,
you said 10%.
About 10%. So that's something that the surgeon really tries to sort out with the patient. Is like, hey, we have this less invasive option. About 90% of the time, it's going to be good enough. But if it doesn't, a few months later, you're going back to have a second operation and to take that bullet out and actually do the drilling and take the arthritis out to really definitively treat the problem. So the results with the X-stop have been really good. Again, it's a great minimally invasive or less invasive way to treat the stenosis.
Which is the goal.
Yeah, exactly. And not all surgeons around the Detroit area are trained in it, so just finding a surgeon that's trained to do the X-stop can be a great option for some patients.
Okay, great. Mary from Southfield, I've heard of spinal cord stimulators helping for long-term pain. What do you think of these devices?
Well, I actually do a fair amount of spinal cord stimulators. I mean, because when you look at, again, the whole gamut of procedures that patients can have for spinal pain, either they've run through all those options, sometimes they've had surgery or multiple surgical procedures, and say they're still having significant debilitating pain. There's got to be a way to kind of decrease that pain or modulate that pain just so they can resume a more normal life as much as possible, better quality of life than what they have from the severe, intractable low back pain. So, and that's where there's a couple options nowadays for that, to basically just mask the pain, just cover the pain when everything else has failed. And those include things like an implanted morphine pump, or what Mary's talking about is a spinal cord stimulator. Actually, the comedian Jerry Lewis has one in his back.
Really?
And he runs around the country and giving talks on how well it's worked for him.
Right.
But basically, it's a small wire that goes into the back, kind of basically in the middle of the back, and it creates a sensation of numbness from the waist down, to basically, again, just masking the pain in the lower back and down the legs. So you're basically trading the severe daily pain for more of a sensation of like a numbness, tingling.
But you can still function.
The legs move just fine. It's just it's only stimulating the sensation fibers in the back. So the legs work just fine. It's just they're having numb, almost like a pins and needles, like your foot fell asleep kind of feeling.
Right.
Sounds crazy, sounds sci-fi, but they actually work pretty well.
They actually work very well. I think very highly of them. As far as all the different types of treatment that we offer with pain management as a specialty as a whole, these have some of the best long-term benefit. So a lot of patients, when you're talking about injections, and even sometimes surgery, when you look at more like 2-3 years down the road, people end up having pain for a lot of different reasons. Right. And with spinal cord stimulators, they have the best long-term data for continued pain relief. So I actually think very highly of them. Not many people want to do it because it's invasive and it's scary to think about putting a foreign object in your body, but for the appropriate patient, they can work very, very well.
Yeah, but it is a pretty simple surgery. I mean, it's an outpatient surgery. It goes into a small incision on the back, so it's not all that bad for patients. And most patients that I'm doing that surgery on, I've already had multiple back surgeries, elsewhere, and now they're looking for something just to kind of cover the pain. So when you compare it to the surgeries they've had to the spinal cord stimulator, usually it's like a mosquito bite for most people. It's usually not an issue for pain.
Initially, it's like it's very similar to doing an epidural, and there's a trial period where nothing is implanted permanently, and you get to try to see what benefit it has for you, and then you get to make that decision about whether you want to do the implantation of the device.
Okay. Jessica from Macomb, I am a 35-year-old with severe neck and shoulder pain. I have a small frame with a large chest. The x-ray didn't show anything major except mild bone spur formation, arthritis, along with my C4, C6 vertebrae. I have undergone 8 weeks of therapy, which has lessened the pain but not eliminated it. I take muscle relaxers and pain pills daily just to function. What is my next step?
Yeah, that's a great question. I mean, from what she describes, we certainly see younger patients with a lot of upper shoulder and back pain who have heavy breaths, and it can be a real problem that can again give us a real hard time trying to manage that on a long-term basis. So again, only knowing what Jessica said, I mean, sometimes those is an exact reason why someone might get referred to a plastic surgeon, maybe even think about breast reduction surgery to help reduce the amount of strain on the neck and upper back.
Yeah, to be, 35 years old and having to take muscle relaxers and pain pills every day just to function, as she says, I mean, that sounds pretty extreme for a 35-year-old to have to deal with that.
Yeah, but at that point, it's no longer a cosmetic surgery. It's really is a medically indicated procedure.
Okay, great. Well, again, we are talking to doctors from the Michigan Head and Spine Institute. If you are suffering from head or neck pain, take the professional's advice. Call the expert physicians at the Michigan Head and Spine Institute at 1-877-784-3667 to schedule an appointment today, or you can visit the website, since you're already online, www.mhsi.us for more information. If you'd like to see Dr. Vena or Dr. Monroe, just call 877-784-3667 today. Again, you see patients in Mount Clemens, and you see patients in Novi, Chesterfield Township, and we pretty much covered Metro Detroit. You don't have to go very far to find one of these excellent doctors. And is there anything else that you really wanted to add today? I have to tell you, I'm quite surprised at the amount of non-surgical options that there are today. I guess I just assumed you have back pain, you have a choice. You go to the chiropractor, you have surgery, or you live with it. But for someone that doesn't have, haven't dealt with a lot of back pain, that just seems to me like those were the issues, but the options. But you have quite a few non-invasive treatments.
Oh yeah, and one of the nice things about MHSI is, like I said before, they employ almost every specialist that would be required to maximize that collaborative team approach to maximizing pain treatment, to help avoid surgery, and even to help treat pain coming from a failed surgery or pain after surgery for whatever reason.
Right, and it's nice to know you're going to a place where you have qualified doctors all under the same roof, neurosurgeon, physiatrist, chiropractor, all in one area. And actually, we have an email that's interesting from Tracy in Ann Arbor. Does the Michigan Head and Spine Institute deal with people who have multiple sclerosis with severe back pain from L1 to L5, as well as 2 herniated discs in the neck, C4, 5, and 6?
Yeah, and that's obviously a lot of issues, and I think what's great about what Michigan Head and Spine is, again, we have all those specialists that can deal with all those issues in a real, really give a broad overview of one particular patient and really get them to the people that can help handle each of those individual pieces. Again, although we're a group of 14 neurosurgeons along with all the pain management folks, people sometimes think they're going to see a surgeon when they come to MHSI.
Right.
But the reality is we have everybody else around us that can take care of people's pain issues for their neck or back, and not necessarily going to need a surgery. And the other thing I think that is very nice from the surgeon standpoint is that if I see someone that I think is not better served with surgery, and you send them to a physiatrist or to the chiropractors in our practice, there's the communication is all in the same record, so we can see what everybody else is doing.
Right.
Really accessible.
And what they're prescribing, which is important.
Right.
Well.
So everybody knows what the other person is doing, so it keeps it very smooth. And from the patient's standpoint, it's very, very seamless. Because sometimes you end up going to the surgeon. Well, you don't need surgery. Now you're going over here to this doctor, and over here to this doctor. Nobody's talking to each other, and it can be very frustrating for patients that way.
And I think you lose some of the information for the doctors, because what my doctor tells me, and then I go to another office and try to tell that it's almost like the pass the message along. By the time it gets to you, it's completely different.
Right.
So that's eliminating that miscommunication, because you're speaking direct. The right hand's talking directly to the left hand. I do have a question for you though about if someone who's listening today and they've had back pain or they've had neck pain, they've kind of been putting it off because they really don't know who to go to. Who would they start with? Say I just have lower back pain. Recently developed or have been dealing with it for a while. Do I go to a neurosurgeon? Do I come to you? what do I do?
have different answers for that
But for someone that calls today, the Michigan Head and Spine Institute says, hey, I have back pain. Will they help them find the right doctor for them?
They will, and I think a lot of it depends on what the issue is going to be, what the people that are answering the phones can kind of sort out and tease out what they're exactly suffering from. But I think probably the best person to make that initial triage is one of the people like Dr. Monroe, so they can kind of see them and evaluate them, start the initial treatment process, see what they're going to need, and kind of start that again. Because as a surgeon, again, a lot of times surgery is not the right thing to start out with. It's like, oh, we're going to send you back to someone like Dr. Monroe to start the whole process of pain management, because surgery really should be toward the bottom of the list as to what you're going to get to address your pain. So you do the least invasive to the most invasive. So that's generally how we would start out.
Okay. Well, I just want to remind everyone again, if you are suffering from neck and back pain, you really should take the professional's advice. Call the expert physicians at Michigan Head and Spine Institute at 1-877-784-3667. Or you can schedule an appointment. You can go and visit www.mhsi.us. I went on the site last night, and I have to tell you, it's very clear, very easy to understand, and there's lots of information on that site. If you'd like to see Dr. Vena, again, he's a neurosurgeon, or you'd like to see Dr. Ann Monroe, she's a physiatrist, you can call 1-877-784-3667 today. And again, there are locations all over Metro Detroit. You don't have to go very far. And there's really just no need to suffer. Obviously, with all of these methods and treatments available now, I think people aren't quite as scared as they used to be, because surgery is a scary thing, especially back surgery.
I see a lot and hear from a lot of people who, especially older people, who say, I was just told, or I just thought that I just was supposed to live with the pain. It was just a natural part of
you have arthritis,
aging. There's nothing to do about it. You just live with it. And that absolutely is not the case. And so I'm very happy to be able to do things like this to get that message out to them, that you don't have to suffer needlessly, that there are things that could potentially offer you a significant amount of relief.
Well, thank you so much again. Thank you. I think this has been, it's been very informative to me, so I hope it's been informative to you as well. And again, if you have neck or back pain, please call for an appointment today. Thank you so much for joining us. I'm Kim Adams, and I hope you have just a wonderful, wonderful afternoon.